GP walk-in clinics, they were a flagship policy for the Scottish Government, hailed as the answer to the 8 a.m. rush for appointments. 10 of these clinics are already up and running, but are they really making a difference? Well, data seen by BBC Scotland suggests that they're not proving particularly popular with patients. And speaking on the programme earlier this year, the chair of the Royal College of GPs in Scotland, Dr Chris Provan, made it clear that he didn't believe that they were the way ahead.
Everybody wants patients to get easier appointments, but I think it doesn't get to the right people at the right time who have the real medical need. It creates a separate, fragmented service. So I don't think it's a good use of public funding in this area. It would be better, the research shows, to put it into normal general practice.
Let's talk to Angela Constance, Cabinet Secretary for Health. A very good morning to you. Thank you for joining us this morning.
Good morning.
We heard from Dr Victoria Shotton as well this morning, who's a GP in Glasgow, who said that these were a headline grabber, that they were expensive, that this money would have been better spent on the existing GP services that were struggling. Are you happy with the progress so far of the walk-in clinics?
So I listened very carefully to the interview with Dr Shotton this morning, Laura, and I'm very encouraged with the developments that we've made thus far with the GP walk-in programme. It is important to emphasise that this is a pilot programme. We are still in the early stages. Within 5 short months, we have opened 10 of the 30 GP walk-in services that we are committed to. So we're still at the early stages, and there will be information published this morning with respect to the first 6 GP walk-in services. And it's really important to stress 2 things. We made a commitment to end the 8 a.m. rush for GP appointments because we heard loudly and clearly people's frustration with that 8 a.m. rush, and I would contend that the patient's voice counts very clearly, but also to reassure GPs, the length and breadth of Scotland, that this is to complement our investment and our work to support and strengthen GP practices. I often use the analogy for, people like my mum, who's in her mid-70s. She very much wants to see her family doctor. Working people, however, have different pressures, and will just be happy to see a GP quickly. So
but are those people using them? Because Edinburgh's walk-in in Wester Hailes, that was the first to open back in February. It's been seeing an average of 25 people a day in these opening months. It's able to see 60. So it's being underused. Do the people of Wester Hailes know that it's available to them?
So it is important that we continue to engage with local communities about the services that are now available.
But do you accept that one is being underused if it's seeing 25 a day as opposed to the 60 that it's capable of seeing?
Well, what I accept is that we are 5 months into an innovative pilot programme that will be fully evaluated and robustly evaluated.
And are you how are you going about that? Because you'll have heard Dr Shotton talking about that questioning how robust the data collection was, because she was saying it's important not just to gather data on how many people are using the service, but actually how many people are being sent back to their GPs because that service isn't right for them.
So if I can finish the first point, which is to say that given the early days of the pilot programme, you wouldn't expect vast amounts of numbers, in the early first days. But in terms of the evaluation programme, it does indeed have to be robust. It's got to be independent. It will be undertaken by Healthcare Improvement Scotland and Public Health Scotland. It will, of course, look at things like value for money, but also, does it help to reduce inequalities? And crucially, with this pilot programme, it's looking at different models. Every walk-in service is operating a little bit differently. And if I can just give, a couple of examples. So in the Western Isles, the pilot there is focused on temporary residents, and that is to complement and support the work of GPs based on the Western Islands to support permanent residents. So you can see, that there's endeavours there to complement existing GP services. The walk-in service in Lockheed is actually based in a GP practice, and this is about testing different models, but in terms of the Lockheed model, it's about testing that access to appointment-free care.
But were you listening enough to GPs in the first place as you went about planning this? Dr. Shotton was saying this was never going to work, many GPs believed. They also said it came out of the blue. There were suggestions that this was a pre-election headline grabber for you, and that this was always going to be an expensive way to deal with a problem that actually needs to be solved by giving funding to those existing practices so that they can expand, so that they can increase their workforce.
So this was very much about listening to patients, as well as being the Cabinet Secretary for Health. I'm at MSP, one of 129 MSPs, and I know from my mailbox, both as a constituency MSP, that local people are very interested in a GP walk-in service.
My question was whether you listened enough to doctors who were warning you that this was not the right approach to solving the crisis in general practice.
You've actually been asking me about patient experience as well as our work with GPs, Laura, and our work with GPs is crucial. And that is why we have invested £531 million over 3 years. And that is about... And that's in addition, I have to say, to the core funding of £1.3 billion for general practice, because what I want to do is work hand in glove with our GPs to strengthen our primary care offer, whether that's through GP services, whether it's through walk-in services, admittedly they're a pilot, but also through Pharmacy First, because it's imperative that people get early access and quick access to primary care. And the numbers who utilise walk-in services will of course be important. There will be figures published later this morning, as I said, based on the early experience of the first 6 walk-in services. But it's also important that we recognise the patient's voice, that we recognise that in many ways this is about more than numbers as well. It is about people who have received very timely assessment, reassurance, and advice and treatment that may well indeed have prevented a further problem down the line.
Okay, if I may move on and ask you about treatment for rare brain cancers. It's something we've talked about a lot here at BBC Scotland, and particularly on Radio Scotland Breakfast. I don't know if you heard last week, we spoke to Kimberly Borthwick. She was on the programme recently. She's a 35-year-old mum. She's been diagnosed with a highly aggressive brain tumour. She may not live long enough to see her twin boys start school, and she very much wants her legacy to be better treatment, better drugs, more trials, but also a minister for rare cancers. If you wouldn't mind, here is a little bit of what she had to say.
I would like kinder treatment, more effective treatment. I think, one, access to different treatments that are available overseas. There's a device called Optune, Tumour Treating Fields, which is available in the 7 other G8 countries. The United Kingdom are the only one not to provide that on the national health. I got that through my private healthcare. So I would also like the neuro-oncologists to be more informed and connected with the trials and the treatments that are available out there, because the amount of doctors I've met that have never even heard of that treatment, and that's been handed out left, right and centre in other countries. So they get surgery, chemotherapy, radiotherapy, the same as in the United Kingdom. That was my standard of care. They then also get, in these 7 other G8 anyway, they get this option, tumour treating fields. We don't have that option here.
So that was Kim's experience, Minister. I don't know if you also saw Archie Goodburn competing in the Commonwealth Games. We've also talked to Archie lately about his diagnosis, his call as well for better funding for these rarer cancers. And he talked about it even last night after losing out on a medal. He said that dream didn't come true. But one of my other dreams is that we see a future where brain cancer isn't the biggest killer of patients under 40. Why is it that survival rates for many other cancers have improved over the decades, but they have remained the same for brain cancer? Yeah. Are you able to help us understand why that is?
I hope so, Laura. And if I can say, if I may, I'm very grateful and actually humbled by the personal testimony of Kimberly and Archie. And, they have been inspirational patient, advocates and the work that they've done to raise awareness. And, it wouldn't have been easy for them to take on that role. It is very true to say that the survival rate for brain tumours has not improved at the same rate that other cancers have in terms of survival rates. So therefore it does require that additional focus. The symptoms for brain cancer can be quite vague. They can be associated with common ailments, and as part of our early detection cancer programme, it would be remiss of me not to say that people should seek advice if they are having persistent and unusual symptoms. Our cancer strategy for Scotland, it does have a focus on those cancers that are thus far less survivable, and that includes brain tumours, and has a focus on improving outcomes. Part of that, for example, is our investment in particular research and treatments, but also...
Do you accept, though, that this might not sound enough for people like Kim and Archie who are having to be advocates for themselves, who in some cases have had to seek other treatment, pay for different treatment, and in Kim's case, pointing out treatment that is available to patients in other G8 countries? Do you understand as well their frustration?
Of course I do. I understand the frustration as best I can as someone who's not currently in their shoes, and that is why I'm saying this morning that we are determined to have that additional focus on cancers where the survival rate is much poorer.
Let me ask about care as well, if I may. Andy Burnham has said that he's open to exploring a care service system that would be free at the point of use like the NHS. Now, obviously, the Scottish Government had planned for a national care service. The legislation was passed, that policy ended up being abandoned. Is this something that needs to be looked at again?
So I would very much call on Andy Burnham, the new Prime Minister, to recognise some of the burdens that previous UK administrations have placed on social care, whether it's the ENICs, the Employers' National Insurance contributions. We are all continuing to live with the impact of Brexit. We know there's an 81% drop in the number of health and care worker visas. These are important matters that do indeed need addressed. We need to have a better, more collaborative debate about reform in Scotland, reform of health and social care more widely. I remember very well that while some opposition parties, Labour Party, Tories, were very opposed to the Scottish Government's proposition for a national care service, but what was lacking was serious alternative propositions. And what I want to do is actually build a consensus on the way forward, because that's in the interests of our patients and the country.
Thank you very much for your time this morning. Angela Constance there, who is the Cabinet Secretary for Health.